are going to have, as always, an early stage investigator present, and then she will actually introduce our distinguished speaker from Atlanta at Emory, who I've known for a really long time, and I'm just delighted to have Igo Afokaton here with us. So Lauren Suchman's going to start, and we are excited to have her as an assistant professor in the Institute for Health and Aging in the Department of Social and Behavioral Sciences. Here at UCSF, she's affiliated with IGHS and the Bixby Center, and did a PhD in anthropology, which is so interesting, and her MA in population and reproductive health research, and in Thailand. And she is working on sexual and reproductive health and gender equity in HIV specifically. So really interested in women's, for example, living with HIV who are at risk for HIV, and the international perspective on their access to sexual and reproductive health services. So just submitted a K, and is going to give us a little talk on our research, and then she'll introduce my favorite, Igo.
Thanks so much, Monica. Nice to see everyone today. I know it's a tough morning for many of us. It's really nice to be in community with other people who are sharing the same values and interested in the same things. So thanks all for tuning in. Let me share my screen quickly here and get it in presenter mode for you. All right, is that showing up okay, Lauren? All right, the Lauren's S are on today. Again, I'm Lauren Suchman, an assistant professor in the Institute for Health and Aging here at UCSF. I'm going to be talking with you about how providers work with patients going through the menopausal transition. So for some background, the menopausal transition, which is the approximately 5 to 10 years around the time of a woman's last menstrual period, is a critical inflection point in midlife cisgender women's health. There are common symptoms of menopause include things like hot flashes, sleep disruption, and cognitive changes, which can impact quality of life over both the short and long term. And associated hormonal changes can increase long-term risk for chronic conditions, most notably cardiovascular disease and osteoporosis. Cisgender women living with HIV experience more menopausal symptoms and greater HIV symptom burden, and severe menopausal symptoms have been associated with suboptimal engagement in HIV care and treatment in a couple of different studies, one of which is cited here. However, women with HIV in the US tend to underuse treatment for symptoms compared to their seronegative counterparts. To bring this into context here at Ward 86, over half of the cisgender women who seek care are in their prime menopausal years, which is about ages 45 to 60. However, the literature suggests that most providers currently caring for women with HIV, and much of this, I'll note, is actually coming from Europe. We have less information here in the US, may have difficulty differentiating between menopausal symptoms and symptoms of HIV or ART use. And many have received minimal training on menopause and how to manage associated symptoms, specifically or especially using menopause hormone therapy, which is sort of the gold standard in treatment. And as a result, may not be aware that MHT is safe and efficacious for women with HIV. And I'll just note quickly that this is largely due to the Women's Health Initiative study, which was NIH funded. Preliminary results came out in the early 2000s when the study was actually stopped because they found that MHT was unsafe in certain populations. Later research has shown that it actually is safe in many scenarios, and many of these results have been sort of rethought. And so now we know that it is safe and efficacious in many cases, but that the legacy sort of lives on. And so this led me to ask, how do providers who care for women with HIV work with their patients to help them manage the menopausal transition in this larger context? So this is a very busy slide with methods. I'm just going to go through it really quickly for the sake of time, but you'll see this was a cross-sectional qualitative study with a relatively small sample size of about 15, and actually 15, not about, and just finished data collection. So these are very preliminary results that are coming out now. Oh, whoops, what happened? Okay. Conducted data collection into clinics that serve women with HIV in a major urban area, and conducted interviews over Zoom with different types of providers, which you see on the right side of the screen, including prescribing providers, RNs, MSWs, and PhDs in behavioral health. Interviews lasted about 40 minutes and providers received a $50 Amazon gift card for their time. And we analyzed the data using deduce and thematic analysis. So the first thing we found was that to the extent that providers felt that they were competent managing menopause with their patients living with HIV, they developed their competence through sort of a mix of personal experience on and off the job. So most participants rated their competence as either neutral or mid-level. Providers with a clinical degree remembered sort of minimal training in menopause and even less or no training for those who had a non-clinical degree. None of the providers interviewed had any training in menopause and HIV specifically, though many were interested in receiving such a training. And most providers said they sort of established their competence through either many years on the job or personal experience with menopause. So for example, you see this quote here in orange, in sort of teal on the bottom, an MSW between the ages of 50 and 59 who said, except for I went through menopause myself, right? So I had to find out what am I feeling, what's going on with my body because nobody explained it to me. And this was pretty common. Several providers said that they mostly learned about menopause, basically having to do their own research when they went through it themselves, and then sort of felt more comfortable talking with their patients about it as a result. Conversations about menopause in the clinical setting were sort of catch as catch can and were typically prompted by patient concerns about specific symptoms. So these were either direct complaints or they came in the context of other medical issues. So those who I think, and this is again something we're still trying to tease out, but those who were sort of more burdened by the symptoms tended to maybe present with them and ask for some help, whereas in other cases, they might just come up in the context of a larger conversation. So here's this top quote here where a PhD in behavioral health said, usually we're focusing on other things, but then they'll mention, oh, I'm having this hot flash. Oh, I have these hot flashes. So it'll come around as part of the other things we're discussing. Some providers suspected, and this is something that I'm going to be looking at in a complementary study with women living with HIV themselves that I'll be launching soon. Patients may be more likely to discuss menopause with providers who they deemed especially trustworthy, either through patient experience, so sort of establishing a relationship over time with a provider, or perceived provider experience. So again, this idea that providers who had experience with menopause themselves or who patients believe might have menopausal experience might be more, patients might be more likely to talk to them about it. And some providers also thought patients may feel concerns related to menopause don't actually belong in their regular medical visits, especially with primary care providers. And finally, menopause care is highly individual and takes the full care team. So providers, and this was interesting. So sort of contrary to the literature, and many providers seem to feel like they actually had a pretty good sense of whether or not patients were going through menopause as opposed to experiencing other kinds of symptoms. Many said that they looked at sort of a constellation of symptoms to determine if a patient was going through menopause and needed treatment. Physicians were most familiar with MHT and recommended it as necessary, probably not entirely surprising since they're the ones who are actually able to prescribe it. Non-physicians referred potential cases to relevant providers on the care team. Many non-physicians were aware that MHT is now considered safe, but the WHI's legacy lives on. So for example, this nurse practitioner in the orange here said, when I was trained over 10 years ago, it was more of the older school of thought of avoiding hormones. I know that my colleagues in OB-GYN are talking a lot more about these days about how hormones should be started in many more people. And several providers recommended alternative treatments to their patients as they felt it was appropriate. But I'll just note that most of these alternative treatments don't actually have any evidence behind them at this point. There's very little evidence on menopausal treatments in general. So in conclusion, providers knew their patients well and could often differentiate menopausal symptoms, contrary to much of the literature, but would benefit from training on the intersection between HIV and menopause specifically, especially among non-physicians. made treatment recommendations based on what they knew about their patients and had gleaned through their own experience. But there's little evidence out there that they can rely on, especially when thinking about alternative treatments to recommend. And may need to take the initiative to start conversations about menopause with patients rather than having patients come to them with those concerns. But recognizing that there are many, many things to deal with in a relatively short time in those visits. And so something that I'm going to be looking at also more in this complementary study with patients. Here are a few suggested resources for anyone who's interested in this, one on the provider side, a couple on the patient side, and just noting that I have yet to find anything specific on HIV and menopause specifically for providers, but I believe that there's a team at Mass General working on that now. And many thanks to my mentors, Elise Riley and Aisha Appa, my research support, Carrie Spiller and Jessica Newson, who I know is here. Hi, Jessica. And then thanks to the Bay Area CFAR for supporting this with a RAP award.
Any questions specifically for Dr. Such? I mean, I think you are looking at reproductive across the lifespan. So that's also, you're focusing right now on the menopausal transition. And I think it was really helpful about the amount of data that came out of Weiss on this. So that's why this is a really great segue to the Weiss Max study. And unless there are any, and very best of luck in your K. So unless there are any very specific questions, I'm just looking for this. And I think it's really important to assess the provider aspect, just because there are interventions that can be done, and there are provider interventions and hormone replacement therapy. We will maybe transition then to the Weiss Max with you introducing Dr. Fulkin.
Can I ask one question?
Oh,
Sorry.
yes, please. Sorry. Okay, go ahead.
Hi, Lauren.
Hi, Rebecca.
Thank you for doing this work.
Nice to see you.
And great to see some of what you're doing. Are you looking at any of the non-hormonal treatments like fezolinetant and any of these newer medications at all?
Not so much. That didn't really come up. I think there's relatively little. I mean, I think people are probably aware. Actually, I'm not going to speculate on that one. I didn't ask about it. I did ask a bit about SSRIs to manage hot flashes. Some were aware of that, not a lot. But I think in this case, in this population, especially, so many people are already on it that it might be hard to distinguish different types of uses for SSRIs, like to manage hot flashes. But yeah, it's a great question.
Thanks.
Monica,
I'm so sorry. While we're waiting for Ego to come back on so that Lauren can introduce him, actually he lost electricity.
Oh, no.
I wanted to see if Jenny Price and Rebecca could introduce the idea of working with the Weiss Max here at UCSF, because as Ego's going to explain to us, we are absolutely a site of the combined cohort study, and getting one purpose of these seminars is how to get involved in our amazing HIV research. So I'm wondering if Jenny, I think you were going to unmute, or if you can't on camera, maybe Rebecca can talk about it.
Yeah, hi everybody. For those of you I haven't met, my name's Jenny Price. I'm actually a hepatologist at UCSF based at Parnassus, and I'm one of the NPIs of the MaxWise combined cohort study. And you'll hear more about the cohort in Ego's talk, but just for very brief background, the MWCCS combines the former WISE cohort, which I think is what Ego will be talking about, which is a cohort of women with and without HIV, with the MAX, the multicenter AIDS cohort study, which is men with and without HIV. The two cohorts combined in 2019. And so now it's one very large cohort, the MWCCS. And in this last cycle, we have re-enrolled people from former WISE and former MAX, and also recruited new participants. So we're a cohort of about 5,000 participants, again, of men and women and trans and non-binary individuals, and with and without HIV. We have a very large repository, ongoing repository, prospectively collected, but also with 20, 30 more years of samples. And right now we're doing annual core visits with additional 6-month visits that might change in the next cycle. But a lot of prospective data collection. If you want to become involved, please contact myself or Phyllis Tien or Brad Oizorat. We really are welcoming to all sorts of investigators. A lot of people on the screen here I recognize from sub-studies and leverage grants. We want to make ourselves as accessible as possible to the larger UCSF community, and please just don't hesitate to reach out to us. We also have a great website that I'll drop in the chat that gives more granular information about the data collection instruments, some of the prior publications, and also ways to get involved, including the information about how to submit a concept sheet. I happen to be the co-chair of the liver working group. I know Rebecca is one of the chairs of the metabolic working group. I can't see everybody else on here to see if there's other working group chairs. It looks like Ego's back.
Yeah, I'm back. Sorry about that.
You wrote electricity cannot be guaranteed in the South. Is that right? So, great. It is time for Lauren to just do that. Thank you.
Yeah.
Welcome back. So glad that you could be here. I am so pleased to introduce our speaker today, Dr. Iko Ofotakun. Dr. Ofotakun is the Grady Distinguished Professor of Medicine and Associate Dean for Research Development at Emory University School of Medicine and Professor of Behavioral Health, Social and Health Education Sciences at Emory University's Rollins School of Public Health, as well as co-director of the Emory Center for AIDS Research Clinical Core. And especially relevant to his talk today, Dr. Ofotakun is the site PI for the MaxWise Combined Cohort Study. Dr. Ofotakun earned his medical degree at the University of Benin and his MSc from Emory. He began his career as a medical officer in Nigeria, where he first developed an interest in addressing HIV-related inequities with a particular focus on women's health, a thread that has run throughout his career. Dr. Ofotakun focuses particularly on the threat that age-related comorbidities pose to healthy aging in persons with HIV and has led groundbreaking translational research in this area. His work has contributed to updated HIV treatment guidelines issued by the U.S. Department of Health and Human Services and the World Health Organization, and has been recognized with multiple awards, including most recently the 2024 National Foundation of Infectious Diseases Maxwell Finland Scientific Achievement Award. Notably and admirably, Dr. Ofotakun's interest in addressing inequities has extended to training and mentoring women and underrepresented populations entering into biomedical research, both in the U.S. and globally. And he leads several related programs, such as the Georgia CTSA KL2 program and the Emory Building Interdisciplinary Research Careers in Women's Health. I'm honored to have had the privilege of giving the opening early stage investigator talk today and to welcome Dr. Ofotakun to UCSF. His talk is titled Understanding the AIDS Epidemic Through 4 Decades of Longitudinal Observational Data, the MaxWise Combined Cohort Study. Please join me in welcoming Dr. Ofotakun.
We're very excited to have Dr. Iko Ofotakun. This is actually a reschedule because the power went out in the middle of his last presentation, so we didn't get to hear this update. Dr. Ofotakun, I've known for a really long time. He is the Grady Distinguished Professor of Medicine at the Emory School of Medicine. He's a professor of behavioral, social, and health education sciences at Emory. He's the associate dean for research there. He's the associate division chair for research in the division of ID. And he has really contributed in many ways to the field of HIV medicine, has independent research grants, mostly in the areas of comorbidities. But what he is going to talk about today is the fact that he is the principal investigator of the combined cohort study, the Weiss-Max study at Emory, which has 9 sites around the country. And he's going to focus in on the MaxWise cohort and the research that he's done within that. So thank you so much, Iko, for being here with us today. And we're really looking forward to your talk.
Thank you so much, Monica, and thank you, UCSF CFA, for having me back for what a golf player will call a mulligan. I promise you the electricity won't go off this time around. It tells you we still live in the South. Yeah, I'm really excited to be here. and to share with you our activities within the Max-Wise combined cohort study. Monica, you will recall when we became part of the Max-Wise combined cohort study, that was almost in 2013.
Amazing.
12
Wow.
years ago, we were putting the application together. I remember how many times I called Monica asking her advice, and the rest is history. The reason we're part of the Max-Wise cohort today is because of the contribution of the UCSF site. And even after we became funded, we leaned heavily on the UCSF site to really develop our infrastructure. And we are so grateful for what you all did for us. What I want to do today is not rocket science. I just wanted to share with you how a cohort study can actually contribute to the understanding of an epidemic. And I think from recent history, infectious diseases history, there's no lack of epidemics. It's the HIV epidemic, it's the ongoing TB epidemic, it's Zika, it's Ebola, and of course, we just went through the mother of all epidemics, the SARS-CoV-2 infection. So this is the overview and outline of my presentation, just to reintroduce those of you who are not familiar with the Max-Wise cohort to this cohort, and use this cohort to highlight the value of observational cohort, and then share some of the key findings from the cohort and how we at the Atlanta site have actually leveraged this cohort to advance both science, HIV science, and career development at our site. These were all things that we learned from the UCSF group, because they were there many, many years before we became part of the cohort. So in December, towards the end of last year, the Max celebrated the 40th anniversary. So making it the longest cohort study, prospective cohort study of HIV anywhere in the world. And then the WISE also celebrated their 30th anniversary. So the WISE was started 10 years after the Max was started. So Max was started in 1984. Can't believe it. That is at a time when we didn't even know what HIV was. We're still struggling with what the name of HIV was. Should we call this a new entity? And then initially it was mostly, as you all recall, it was mostly gay men especially from the coast, either from the West Coast or the East Coast, who were really affected by this epidemic. And then 10 years later, it became obvious that this was not just a disease of gay men. Women were also affected. And then the WISE was started in 1993. And today we have 13 sites, clinical research site, and a data coordinating site. And most of the sites are listed on this slide, and you can see that they are mostly located in areas where you have high burden of HIV epidemic. So towards the end of 2018, the WISE and the Max were change institutes. They moved from the NIAID that funds infectious diseases to NHLBI. And one of the things that was done was to combine the Max and the WISE into one large cohort, now referred to as the Max-Wise combined cohort study. And one of the things that happened when these two cohorts were merged was that the scope of work was actually expanded. In addition to studying the pathogenesis and the natural history, it became more of an aging cohort, studying aging-related comorbidities. So in addition to collecting the basic natural history, treated history, samples such as blood, urine, saliva, genital secretion, we then expanded the scope of work to include characterization of end organs. So we were doing things like hearing and balance testing, STI testing, microbiome, fibroscan on everybody that was recruited, what you call the CAT-MH, the BRACE plus oral health was included, PFT with its CIDI to better characterize mental health status, and a vast majority of participants had echocardiograms. There was also sleep studies like MRI and to characterize the brain in a highly selected group of participants. So this was it became more of a comorbidity study to look at what happens when people age with successfully treated HIV infection. And so this is where we are today with the demography of the cohort. We have currently about 5,000 or almost 6,000 people that are recruited into the cohort that we're following, and some of them started the study in 1984. There's somebody in the max cohort, mass side of the cohort, that is 97 years old. People that have been in the study from 1984, 1993, who have been followed and have never missed a single study visit. And the reason I show this slide is just to highlight the diversity of the cohort. You can see here significant number of African Americans, significant numbers of white, and you can also see just really a large cohort of Hispanics, giving you the opportunity to really look at not just the group as a whole, but if you wanted to hone in on a particular specific population, this is it provides enough robust data to be able to study, for example, Hispanic male, Hispanic female, Black male, Black female, or everybody together. The other aspect of this to highlight is really the retention rate within the cohort, which is unprecedented. Remember, we're dealing with a population that is traditionally described as difficult to engage in research: African American, Hispanic, gay Black men, gay brown men. These are, and to look at cumulative retention rate of 30 years for the Ys, 40 years for the Max, of ranging in the 80%. This is really something that is unprecedented. And Monica, who was part of the Ys for many years, know what we did. The amount of community engagement, the amount of relationship building, that really existed between investigator within the cohort and the participant and the community, not just the individual participant, but taking the study into the community where the participant is and actually engaging at the community level, really what had actually really account for this high level of retention and participation. And the story here, it's not just people showed up, it's the fidelity to the protocol. People showed up, and a lot of the things that needed to be done were done. Bloods were collected, hair samples were collected, genital samples were collected. They underwent all of the study procedures. So we have retention in attendance, retention in terms of fidelity to the protocol. So when we were combined in 2019, one of the things we focused on was really in enriching the cohort with more the particular group of people that were most affected by the epidemic. So we enriched with men, particularly Black men who were having sex with men. So this is the population of people. We enrolled almost over 2,000 people between 2019 and now. Most of them were gay men, Black men, Black and brown men in the southern part of the US. Most of them, the vast majority of them came from Atlanta. So again, just showing you how deeply phenotyped this group is. Whatever information we needed from them, they provided. So this is just showing you the demographic characteristics of the participants. The education level, marital status, income level. Again, we're dealing with majority of people who are at the margins of societies. Significant number of people with low level of education, significant number of people that are below the poverty line, significant number of people that are single or never married or divorced. And here again is the age distribution. Here, the point here is to highlight that this is an aging cohort. Look at the proportion of people that are above the age of 60. You can see here across the different demographic, women living with HIV, women without HIV, men with HIV, men without HIV. You can see here, especially for the men, the proportion of people that are greater than 60, that proportion is rising significantly. Again, giving us the opportunity. One, it's a testament to the success of treatment, that we have been able to sustain people, keep them alive, and then also gives us opportunity to study some of the aging related comorbidities that we are interested in. More behavioral characteristics of the group. This slide will be made available, and a lot of this data is publicly available at the MaxWise Combined Cohort Study session. So significant number of people using illicit drug, marijuana, high level of smoking, about close to 30% of the population. Alcohol use is high, and binge drinking is also quite high in this population. Here, the use of PrEP use is significantly low, given that this is a high-risk population. So for you to be eligible to participate as an HIV-negative person in the MaxWise, you have to have a risk factor for HIV infection. So technically, every one of these individuals is eligible for PrEP. Based on the CDC guideline or recommendation. And what you can see here is really significant low uptake of post-exposure prophylaxis, particularly among women, those women living in the southern part of the US. These are more psychosocial data that is available within the MaxWise, for those of you who do social behavioral studies, again, just highlighting how deeply phenotyped these individuals, this cohort is. And then the quality of life data. And here is a history of co-infection, hepatitis B and hepatitis C. And the thing to highlight here is that contrary to what you would expect, co-infection is not as high as what would have been expected for this population. Whether you're looking at, if you look at the column here, you're looking at hepatitis B or hepatitis C. The rate of co-infection is significantly low in this population. XTI, the major STI that we see in this population is syphilis, particularly in men who have sex with men. If you look at gonorrhea, you look at chlamydia, rates are significantly low in this cohort. So here is a history of treatment. Again, this is an unusual population. There's high rate of ART uptake. I think overwhelming majority of the population is on treatment among those who are HIV positive. And like the rest of the UI, the workhorse of treatment here is the integrase base regimen. And adherence is also high in this population if you look at self-reported adherence. And even when we look at objective measure of adherence using hair level that Monica championed within the WISE and dry blood spot, the level of adherence in the population is high. Again, overwhelming majority of them are we would say 74% of the cohort is virologically suppressed. which is slightly, we would hope it would be more than this, given a cohort that is followed at least twice every year. For majority of them, you would expect a higher level of virologic suppression. So healthcare utilization in terms of insurance data are also collected, as shown on this slide. Especially for those that have HIV, most of them have some form of insurance, whether it's Rhinebyte, Medicaid, or private insurance. The bigger challenge is those who are HIV negative, where we have slightly lower level of coverage. And so the question is, why do we invest in this type of observational study? Let me see here. What did I do with my my screen? So why do we invest in observational cohort and epidemics? So one is to characterize the disease and its associated conditions. That is one of the things. And when we started the MaxWise 30, 40 years ago, that was really kind of the primary goal, to estimate disease burden, risk factors, and complication, to understand the trajectory of progression of recovery, if there's recovery, and to understand the pathobiology, biomarkers, and discovery, and then, of course, to find accurate diagnostic tests for treatment and then prevention. So if you use this as benchmark, so let's see how well the MaxWise has done over the course of 30 years and 40 years of existence. See here. I'm trying to figure out how to advance my slide. Give me 1 minute here. I don't know what I did with my slide. Okay, there we go. So if you look at cumulatively since its existence, since 1984, the Max and the WISE cohort have contributed 3,305 publications. This is as of May of 2024 and still counting. And so here are some of the kind of major highlights of the contribution of the MaxWise. This is just my estimate of what I consider to be highlights. So Max was established in 1984. First publication was in 1987. WISE was established in 1993. The first publication was in 1997. And so these are some of the kind of really the timeline of some of the major contribution. One, the drivers of HIV risk. We'll talk a little bit talk more about this in a little bit. The clinical staging of HIV, the protective effect of CCR5 mutation. Immune exhaustion was a concept that was first developed, that first came out of MaxWise. Non-AIDS comorbidity was something that was championed at our site. The role of B cell in the pathogenesis of HIV infection. Inadequacy of screening guidelines for people living with HIV. See here. The impact of biological sex and the accelerated aging clock. These are some of the contribution, kind of landmark contribution that was made by the cohort. So let's take a few of them and highlight a few of them. So this was the work that was done by Charles Renaudot and Roger Dettel, and this was one of the first publications, one of the first few publications of the MaxWise, Lancet in 1987. At that time, we really didn't know much about the risk factor for HIV. This study actually looked at a cohort of MSM for 6 months in order to identify the risk factor for testing for HIV. And what they were able to find, which all of us now know very well, and at that time was really big news, was that receptive anal intercourse accounted for nearly all the new infections. The risk ratio increasing from 3-fold to 1 partner to 18-fold if somebody has equal to or greater than 5 partner. So now you look back and you can see a lot of the science around HIV prevention really developed around these landmark findings. A lot of what we do today, a lot of the emphasis, both the biomedical preventive measure, the social behavioral preventive measure that we currently have today in the field were really driven by this landmark publication that came out of the MACS just within 5 years of its establishment. Now, this is another big paper that now, at that time, was really hot news. Now we look back, we just take the finding for granted. So this is John Fair, who was the PI of the MACS at Northwestern, one of the original PI of the cohort. What John did was to look at the using samples from MACS participants to study, observe that, look at the clinical manifestation in relationship to the staging of immune deficiency. And what they found was that it observed that clinical or hematologic abnormality were found up to 13 times more among HIV seropositive men than HIV seronegative men, on top of depletion of CD4 T cells. So what this study was able to show was that, for example, if you had certain level of immunosuppression, you're going to have certain types of clinical manifestation. For example, we knew that if you have oral thrush, if I look at you and you have oral thrush, I could almost say without even looking at anything that your CD4 cell count is going to be less than 200. If you came in and you have primary CNS lymphoma, we knew that your CD4 cell count is going to be less than 50. This was at a time when in many parts of the world, there was no viral load testing was not available. CD4 testing was extremely difficult to come by. And a lot of the CDC, the WHO staging, clinical staging of the disease, which was used widely in Africa and many other resource-limited settings, actually were driven by this data from the MACS-Wise combined cohort study. This is another old data that was work that was done by Charles Rinaldo and Roger at UCLA. And this was by itself, many of you who are on this call, Steve Dick, Peter Hunt, and many others, you do a lot of work in HIV cure. And they were the first to really recognize that if you have CCR5 receptor mutation, and that mutation by itself is protective. If you are homozygous, your risk of progression, if you have the disease, is significantly reduced. If you are heterozygous, you almost never, even if you are exposed, don't acquire HIV. A lot of the work that is being done today in the cure arena is really driven by this finding. And I think several drugs, for example, Moraviroc, actually came from this concept. And a lot of the work that was done around entry, HIV entry, were also the result of this landmark finding by these two individuals leveraging the cohort. And this is work from Marge Cohen from the Roche site, Chicago site of the MACS-Wise combined cohort study. By the time she did this work, we have already known that if you are placed on ART, virologically suppressed, there's significant reduction in HIV morbidity and mortality. But what Marge did was that they looked at people who were suppressed, and they find out that even with treatment, the burden, causes of death among women with HIV was still significantly higher than what you would expect from the general population. And this is really kind of spurred the beginning of looking into non-AIDS comorbidities, because we knew you treat people, their viral load goes down, CD4 cell goes down, AIDS-related comorbidities, AIDS-related death died, but significantly reduced, but people still had a higher rate of morbidity, but this time related to non-AIDS comorbidity. And this was really what spurred a lot of the work that people began to look at, that, in addition to people dying from cryptococcal meningitis, CMV, there are people that are dying from heart disease, liver disease, and other comorbidities. And this really kind of began this field of looking at non-AIDS comorbidity. And the Max Wise has done a lot of work looking at hepatitis B, co-infection, steatosis, cholesterol issues. And I think the REPRIEVE study actually came from some of the rationale for the support for the REPRIEVE study came from the work that was done, original work, data that came out of the Max Wise cohort. So I'm going to spend the next few minutes talking about what we have done, how we have leveraged the cohort at the Atlanta site. We became part of the cohort in January 1st, so first week of January of 2013. And our interests have been in HIV comorbidities. And we were interested not just only in the epidemiology, the burden, but we were also interested in the biology of some of these comorbidities. And this is work that was recently published by Lauren Collins, who was my fellow, but now one of my colleagues, and clearly demonstrated that comorbidities, the burden is significantly higher in people living with HIV, and this is not news. What was news was that she was able to show that this burden is the preponderance of most of this comorbidity occurs in people living with women relative to men, and that this burden is actually occurs much earlier. The highest risk group were people in their 20s and 30s. That the risk of developing this, of comorbidities occur very early, more in women and at a much earlier age group. And here aside, we built a team science approach to looking at the biology of a comorbidity that brought together a number of people, data scientists, basic scientists, clinicians, social behavioral scientists. And the question we had was, how do we understand the pathobiology of these comorbidities? And I'm going to go through this very quickly. These are some of our publications, looking first at bone, and then the brain, and then the heart. What we showed was that why people really were focused on CD4 T cell, that B cells also contribute to the pathogenesis of HIV-related comorbidities, that in the case of the bone, B cell play a significant role in maintaining bone health, and that the imbalance in the health of B cells in people living with HIV leads to production of increased production of bone-resolving cells, osteoclasts, and decreased production of bone-forming cells, osteoblasts, and that this imbalance in this imbalance between osteoclasts and osteoblasts really was responsible for driving the pathogenesis of bone disease in people living with HIV who are not treated. That is, the viral contribution to bone disease was really as a result of impairment of B cell function. So we kind of really represented this in this schema, that when people have HIV infection, CD4 cell is affected, but B cells are also affected. And B cell function is actually controlled by CD4 T cells. So when you actually affect CD4 cell function, you impact indirectly the function of B cells. So the production of RANK ligand and OPG, proteins that are very key in the maintenance of bone health, not just bone health, even neurocognitive health as well as cardiovascular health that is produced by B cell. There's really an alteration in that balance. And this imbalance is what really drives some of these pathogenesis in the case of the bone. And we also were able to show that we can prevent or block the effect of some of this effect by using a long-acting anti-resorptive agent in treatment of people living with HIV who are starting antiretroviral therapy. We showed that this bisphosphonate, long-acting bisphosphonate, just a single dose, was able to protect the bone, and this effect was long-lasting, lasted for the 3 years, the 144 weeks that we followed these individuals. I'm going to skip this slide here. Again, this is another model where we showed that when you start people on antiretroviral therapy, and that the immune reconstitution that results from the treatment leads to activation of T cells that are being produced. So some of the T, you have increase in your T cells, and especially in adults, these are not de novo. These are not T cells that are produced through the normal pathway where you go through maturation in the thymus. Thymus is already involuted, so most of these T cells are really for homeostatic proliferation of existing T cells, and these T cells that are being produced are actually activated, and these activated T cells contribute to the inflammation that initially drives increased bone loss in people living with HIV. And again, we did a number of experiments showing that we can block this effect. And here is our cardiovascular result. Yeah, let me see, that was led by Ashed Kayumi, who is a cardiologist who lead our Clinical Cardiovascular Institute at Emory, and John Oshinsky, who lead our imaging core at Emory, is a radiologist. And one of the things we showed using this cohort also was that, one, the burden of plaque, coronary plaque, using CCTA and cardiac MRI, that the burden of plaque was about 2 to 3 times higher in the Max-Wise combined cohort compared to the general population. The other thing that we showed that was really interesting was just the progression of stenosis. So when we look at CCTA, at baseline, we see maximum stenosis of about 9%, and then we follow these people over a period of 2 years, from 2019 to 2022, and we saw a 29% an increase in plaque stenosis in cardiac artery stenosis from 9% to 29%, showing that this population is really at high risk of cardiovascular disease. And this is another work that is done by Cecile Lahiri, who used to be a fellow of mine, who is now a colleague of mine at Emory, an associate professor, who was looking at the relationship between reservoir size, inflammation, and cardiovascular disease. And what she was able to show was that if people who are suppressed, who have plasma suppression, or they are virally suppressed, people who are on integrase inhibitor during her K award, they have suppressed viral load. And if you look at rectal tissue, majority of them, I think 90% of them still have replicative competent virus in their rectal tissue. And what she was able to demonstrate was that these people that have, even though plasma viral load is suppressed, but have replicative active virus in their rectal tissue, also have high levels of inflammatory cytokines, looking at D-dimer, IL-6, the TNF-alpha, as well as soluble CD163. And she does have an arrow one now looking at the relationship between tissue viral load and cardiovascular risk factor. So let's end up here. This is another new project we're looking at looking at epigenetic factors as a predictor of cardiovascular, of comorbidities, aging-related comorbidities in HIV-infected individuals. And this is what we're doing with Rafiq Sakali. And essentially what we're seeing from this data was that people who would have HIV infection, who will progress to develop comorbidities, were already predetermined. Where there's epigenetic changes that occur even before they acquire their infection that really determine the group that will progress to develop comorbidities. And we've been able to leverage the Max-Wise, as you all know, too well in CSF, that for career development. And these are some of my colleagues, and Andy Shed, who is now my interim division director, Cecile, Lauren, Caitlin. These are all our small group that have actually leveraged the Max-Wise very richly to grow their career in various aspects of HIV science. So to conclude, there's value in having a long-term observational cohort study. This consistent repeated measure of same large set of symptoms enable deep understanding of outcome of interest. Long-term prospective follow-up enable rigorous assessment of incidence and trajectory. Large representative sample size enable examination of subpopulation. Enormous amount of biospecimen and physiologic study including from dissident support identification of therapeutic target. They offer a robust opportunity for career development, both for early career as well as established investigators. Again, thank you for having me back and really for this opportunity to present to the group. Be happy to take your questions. Let's see if I can stop sharing.
That was such a tour de force. Like, you went over every finding in WISE-MAX, and I think a lot of the findings that you went over really did form the basis for a lot of sort of other scientific objectives and hypotheses that have come out in HIV. So that was amazing. That's exactly what we wanted for this talk. So thank you so much. We only have 2 minutes. That's what we've scheduled. And so I wanted to actually see if there were questions for Ego. We, of course, as Ego already spoke about, have a WISE site here. And Phyllis, I saw what was on the call earlier. She may have had to drop off now, but of course, Phyllis is Phyllis still here? Yeah, she is the PI here. And I wanted to see if anyone had any specific questions for Ego about how to get involved in this combined cohort study, its future. Are we going to stay in comorbidities, even though it does way more than comorbidities? Unique research projects, something about the adherence elements or the exposure elements, the immunology data. So any questions or thoughts that people have. And Jennifer Price, that's right. I'm sorry, Jennifer, you were here to be the other person from the WISE-MAX site. So if anyone has specific questions for Jennifer, she is actually here and can answer them. So anything specifically from this group. I will say that this has been, I started my career in this, not the combined cohort study because that was before it, but in the WISE study, it was a profoundly important experience for a mentee to be able to work with such rich and long-standing data, 40 years with Max and 30 years with WISE now. So any questions or thoughts from early stage investigators on this call? Or from Mallory, who I see is here, and maybe you can make discussion about the social behavioral agenda in this combined cohort study, which is very rich, and we've had people, mentees here really use that database.
Can I ask a question?
Thank you. I think you made the question for me, Monica. Thank you. So we'd love to, like, what are some of the social and behavioral science priority areas, or at least areas that are currently getting good attention within the combined cohort study?
Thank you so much, Mallory. I would say everything, but the part that is fascinating to me is really the intersection of biology and social behavioral findings. We're beginning to understand that a lot of the biological outcomes are really driven. Some of the inflammation that we see with HIV-infected individuals, we attribute them to low-level viremia. We attribute some of them to inflammatory conditions such as CMV and others. But we're beginning to find out that the psychosocial stressors themselves have biological implication. The people are not just that the impact of poverty, the impact of discrimination, the impact of all of these social determinants of health have immunologic implication, have biologic implication. And we're beginning to look into some of those that the reason why we have a lot of these inflammation-driven conditions in this individual predisposition to cancer, cardiovascular disease, pulmonary disorder, and even susceptibility to some of these opportunistic infections is because of some of these social determinants of health, psychosocial stressors.
Great, thank you.
So we do have to end because this went till 11:45 and this was our extra session. And thank you so much for coming. This was a longer C4 seminar, but I thought it was fantastic. And you're really, I will just say that I didn't get to say this with the introduction of Ego, but he also does a lot of mentoring work and a lot of work in Lagos, and really helps train people via D43 mechanism, and is just widespread in his work and extent of the kind of mentoring work that he does in the field of HIV. So really